Hi and welcome to 90 Day Dental Day 17. We're on the home stretch. We've managed to get through quite a number of topics. We've got through smile design analysis, we've got through a couple of topics on occlusion, and today we're going to round it off by talking about the TMJ analysis and muscle analysis. Again, Gary finishing it off with his last session with us. Take it away.
Hello again, 90 Day Dental. Ahmad, thank you for the invitation. This is my actually third but fourth and final piece that you asked me to put together. So thank you again for the wonderful offer to be part of this. What I'd like to talk about is TMJ and muscle exam and evaluation. I'm going to go through a process that might be done differently by some people, okay? And the order of it doesn't matter. The order of it is based on what you like to do. In this case, I'm going to start with a clinical exam of the temporomandibular joint. The questions I have to ask myself: is there inflammation? Where's the disc? Is there pain with movement? Is there pain with loading? Now I'm going to check those things, okay? Those actually three of those things, by doing palpation, by looking at movement, and by listening. The first thing I'm going to do is I'm going to feel for the condyle. So I'm going to put my hands on the side of the head, have the patient open and close. When I feel the condyle moving past my hand, I ask the patient to stop. I'm going to put my fingers on each side of that condyle and I'm going to push in a little bit with about 5 pounds of force. Okay? When I do the 5 pounds of force, I'm going to say, do you feel anything other than pressure? By the way, 5 pounds of force is about the amount of force that will blanch your nail bed if you push down on something. So if you see that blanching nail bed along the edge, then that's about 5 pounds. Once I've done that and I ask, by the way, if they say yes, I'm going to ask some more questions. You know, were both sides the same? What did you feel? And then I try to gauge that. On a scale of 0 to 10, with 0 being no pain and 10 being the worst pain you can imagine, what score would you give each side? The second thing we look at is retrodiskal tissues. Retrodiskal tissues are going to happen behind that condyle. So I'm going to have the patient open as wide as they can. And one way to do that is, as you see on the image here, is to slide my fingers in behind and push forward. I could also do it with the pinky in the ear. If I had the patient close gently on their back teeth and then I put my pinkies in their ear and push forward, I can apply the same force to those tissues. Again, I'm going to say, do you feel anything other than pressure? A lax lateral ligament is something that will occur that I will feel happen. If I have my pinkies rested in the air, patient is open, I'm not going to push in hard and I don't want to push forward, ask the patient to close. What you'll feel is tissue coming back and pushing against your pinkies. If you feel a sound, and I know that sounds weird, but you can feel joint events. When something happens that would be a click, okay, when it's not loud enough to be a click, you might not hear it, but you can feel it with your finger. If they go to close and you feel that pressure coming on your pinkies and then you feel something happen, that's usually the result of a lax lateral ligament. Okay, if they close all the way and you feel something happen there, you get a little bit of noise. I'm going to call it a pop, but I don't always hear it, I just feel it. Then that means probably the lateral aspects of that disc can move. They're not tied down as tightly. The next thing I do is I do something I learned years ago in dental school. I found out that Pete Dawson was the person who started this. He had a thing called Bi-Lateral Manipulation. Tips of the fingers on the inferior border of the mandible. I'm going to arc with them and ride with them, and I'm going to feel what happens. Not much force, 1 to 2 pounds of force. Okay. In later years, we started calling it bimanual guidance, and what that means is manipulation for me was a power word, and so we started talking about it as guidance. In other words, I just need to ride along. It's a skill that is developed over time. What I do is I ride with the patient, okay? Very light pressure, follow the patient, it's guiding. About a second to open, about a second to close, no teeth touching, okay? I just want to feel what happens when they move. And then especially as teeth come near each other, when you feel things tense up and tighten up, it might mean that because their condyles may have seated as you guided with them, that their brain is saying, no, don't do that because teeth aren't going to fit. I just want to feel if there's tension as they guide and as they arc, and then what happens as they bring teeth together. I'm using my hands as sensors. How smoothly do they move? And was it easy, difficult, or impossible? Some people, as soon as you touch them, you'll feel them tense right up. Okay, many people, especially young people, especially kids, if you have kids in your practice, sit down and practice this and just arc with them. And you'll feel they will just let go and let you guide them. Next thing I want to do is listen. What's the easiest way to listen? Well, with your ears, but I would recommend you get out a stethoscope. You have one anyway. Go ahead and listen to what happens as the patient moves. Why would this be good? Well, probably not too many dentists has taken out a stethoscope and listened to jaw joints. I like to do things that other dentists haven't done because the patient might be willing to think something different is happening. Now, if you have a Doppler, you can go ahead and listen to that too. Talk about what you hear because the patient will ask you. Now, why do joint sounds happen? When a joint event happens, because when the patient moves, that disc is repositioning itself throughout the movement. Okay, as you go back and forth, either protrusive or as you saw, there's some lateral movements. If that disc is a little bit moved off on the lateral, and that's what we'll start with, when you open, it's going to tend to recapture it. It'll want to grab it and take it back. You'll hear a noise. The recapture of the disc onto the condyle creates the sound. So I open and boom, I hear that noise. Okay? When I go back, it's going to come back off that edge again if it's on the lateral. Now here's the thing. It's loaded on the medial. So the noise that gets created is a movement that could happen even in a normal joint when I'm biting down and loading because the load is happening on the medial. Laterally, there's this thing that happens. When I close, I may not hear it as much because it isn't being loaded. There's always going to be a reciprocal repositioning in a disc that is movable like that. Okay, joint sounds, you can have more than that. It could be off further than that. In other words, this illustration is showing you one that is permanently displaced. It doesn't recapture, which means for this person, they would have said, I used to have noise, but now I don't. I must be better. Well, in fact, you might be worse as far as the condition inside there. And then the medial aspect can also be off. And when that happens, even in rotation, you may hear noise. Because as the ends of the condyles move, because remember, they're not connected in there straight across, the condyle has wobble, you may get some noise as they just arc in a seated position if it's off in the medial. In fact, the disc could be any of those things, and each side is independent of the other. How do we think that happens? We believe today is from trauma. There's some macro traumas that you see listed here. Macro traumas can certainly cause it, and you remember those. What we think today is the common initiating factor in discal displacements is an injury to the discal ligaments. So we want to look for that history. If you see injuries of history here down, people might not remember, ask them about it. They won't remember. But if you find things in joints that might play back to that because of changes, just recognize that might be why it happened. Then there's micro traumas, all the things you see listed there. Those things can exacerbate a trauma that already existed. Next thing I'm going to look for is range of motion, maximum opening and then open comfortably. And then stretch as far as you can. I'm using a device here from Great Lakes Dental, and they have these little paper things you pop out, these little rulers, and I just wonder how far somebody can open. 19 to 20 millimeters is usually just in rotation. Once you go past that, you begin to translate. What's normal, you should be able to put 3 fingers in. Okay? About 3 fingers. That means that number is going to vary patient to patient. I can use the same device to look at right and left movement. Am I able to move that joint around? I look at range of motion. What does it look like in the horizontal and vertical and protrusive aspects? I need to try to observe this and listen without getting into diagnosis. That's going to be hard if there are things that you see in here. I would argue just own those things for now. Record the findings. Help the patient be aware. Come back to him when you can, but stay in the question. Please don't go to diagnosis yet. Help the patient understand what he or she has there. Muscle palpations. I want to show you the muscles we palpate. The first one is the anterior temporalis. These are the ones I do on every patient. The posterior temporalis. Okay. The posterior temporalis from the side that you can see here, it's up behind the ear and above the ear. The suboccipital, which is not really a muscle, it's an area, and it's where the splenius capitis, longissimus capitis insert onto the skull. There's a little point you can drop into if you come back off the trapezius and before you get to the sternocleidomastoid, which shows up on our patient here. The trapezius, the first part is that spinal portion where it comes down along the back, okay? And if I follow that down, I can go into the body of the muscle and I can start looking for trigger points. Are there places in that muscle that are tender? Sternocleidomastoid should be soft when moved around. All right. I also want to look if I have the patient lift their head, it'll pop out. Let's palpate it also while it's flexed. There's also a little spot where the 2 heads separate. If you can find that little spot and palpate in there, very often it will become tender on an overworked muscle before other areas become tender. Hyoids, I'm going to go down along under the chin and then down. I don't need 5 pounds of force here. What I'm feeling for is any tenderness there. Sometimes patients will say my throat feels sore, but I don't have a sore throat. That could be muscle. The anterior digastric, actually this shows the whole digastric. The posterior, where it comes up through the hyoid and up to the skull, we can palpate the anterior easily, and that's part of my normal palpations. It runs genial tubercles to hyoid bone, and it's hard to feel when they're comfortable. If the patient retrudes their mandible, sometimes you can feel that. The masseter, all right, and there's kind of 4 places on the masseter. I'll look at the anterior border. I'm going to walk along the muscle once it's relaxed. The anterior border is usually under flex. I'm going to go down to the insertion into the mandible and come up to the insertion into the zygomatic arch, although that's on the medial aspect. Those are areas I want to palpate. I want to ask the patient, do you feel anything other than pressure, as I said earlier? The deep masseter is a good palpation, especially if someone points up here and says, I have pain here, but you're not thinking joint. Usually finger, I think joint, but nothing on the joint seems to lead me there. Well, think deep masseter. Deep masseter is a muscle that's underneath the masseter. It runs at a more up and down or vertical angle. And the way you would find it is you'd have the patient open, you'd feel where their condyle is, as we did earlier. And then this time as they close, let your finger come ahead of their condyle. Let their condyle move behind your finger. And what you'll notice just ahead of the green dot is the deep masseter. My finger will be right there. I say stop, and I can push in on that. Okay, and then ask, do you feel anything other than pressure? That's a deep masseter palpation. Stop closing as soon as the condyle moves from under your finger, and then about 5 pounds of force directly in. The medial pterygoid is the counterpart to the masseter. In fact, it looks much like the masseter. You can see on the drawing that it's on the lingual aspect at the same position as the masseter. To palpate that, I need to go in like I'm giving an inferior alveolar nerve block, and then move to medially and come around the roll of mucosa, go back in, and push out. That's where that muscle is going to be. It will often gag patients, so you have to ask, other than gagging, was there anything other than pressure back there? The lateral pterygoids are quite high, as you can see in this drawing. I need to go back in and come up. The buccinator is the muscle that you see on this drawing that I have to go past. But if I can go all the way up and past behind the maxilla, I can palpate the area. And the reason I like that is that it is one that is really, really reactive to occlusion. So lateral pterygoid, here I am going back in behind. I'm going to push up and back, and I'm going to go in. All right. If you haven't felt this one, it can be hard to do. So I'd encourage you, if you have a study club, get some information about how to palpate this muscle and practice with each other, so you can start to see what does that feel like. The other way to palpate this muscle or to test it is provocation. Have the patient move forward, no teeth contacting, and I'm going to push back against them with light pressure, about 5 pounds of force. I'm going to hold that for a few seconds, okay? And then we're going to release together. This is from back when we didn't use gloves, and you'll notice that my thumb is blanched here with Diego. And as I do that, we're going to release together. After the release, I'm going to say, is there any tension or tenderness, tingling or burning up here by your jaw joints? And I usually touch the patient on the side of their head where you see the red circle. The purpose of that is that anything that's a positive response there is a positive response to that isometric test. Okay, the next and last thing we want to look at a joint is their pain with loading. If it hurts, there's one of 3 things if you get a response. Either the disc is not in position, as you see here. Retrodiskal tissues are inflamed so that as the condyle seats, it compresses those. Or the lateral pterygoids are tender when stretched. A leaf gauge creates a tripod that seats and loads the condyles while stretching the lateral pterygoids. So I can test this. And for me, it's a wonderful test device. If you think about this, the reason we use a tripod, if you were standing on a 3-legged stool, how many legs will be on the floor? It's not a trick question. There's always going to be 3 unless you're falling over or trying to balance. If we flip that over and said, let's make those joints 2 of those legs, we put the leaf gauge in the front, it becomes the 3rd leg. If I now apply force, where do those legs, the joints, have to go? They will go to the seated position by default because there is nothing in their way and force is being applied. All 3 legs are going to be on the floor. So a load test is forward, back, close gently on your back teeth. Do you feel anything touching? No. Squeeze gently on your back teeth. Anything touching? No. Go ahead and squeeze hard on your back teeth. Anything touching? If anything is touching, add leaves. If not, I get to squeeze hard. I say, well, hold that for a few seconds. Forward, back, squeeze gently on your, close gently on your back teeth, squeeze gently on your back teeth, squeeze hard on your back teeth. That's the load test. Bites are taken at squeeze gently. This is what it looks like if you're looking at it from the front and the side. Okay, if I get a positive load test, I'm thinking of these things: an internal derangement, disc not in the right place, retrodiscal tissue inflamed, or a lateral pterygoid muscle that is uncomfortable. It's it's been overworked. And overworked muscles don't like to be stretched out. You probably have known that if you've ever gone to the gym after a long layoff. The second morning, you usually feel like, oh my goodness, my muscles are so sore. If it happens early, and I get this early in my response, I'm going to think something inside the joint and I'm going to be careful. But often I could have a patient load and they're not feeling anything. In fact, they might be loaded and then they say, oh, I'm starting to feel something. All right, step one is to see it. If I can see it, then I can start to understand why it's happening. Evaluations and exams are all about those things. Step 3 is knowing what to do about it. And I'm sure that over the next remaining in the 90 days, you're going to hear some wonderful comments and some wonderful ideas about what to do about it. I hope that you enjoyed that one also. Again, my name is Gary DeWood, and I'm from Spear Education. And I thank you again for watching, and we'd love to hear from you out at Spear. Thanks a million.
Thank you, Gary. Really well summarised. The last couple of days have been immense, and if you've missed any of them, do go back and rewatch them again. It's the last 4 days, including today's, that have gone down really, really well and really helped to bring everything together on this. Carrying on, tomorrow we will be finishing off more topics on this and taking it a step further. See you then.